persistent. And ears, mouth, and ears are normal, no thrush, and she has all 20 deciduous teeth, and eyes show no pallor icterus and no cataract. And coming to the hands, there was a rash, erythematous rash in August 2022, which was present predominantly on the knuckles, PIP, and the DIP. And currently, the similar sites are involved, but the erythematous rash have now become hypopigmented and atrophied. There are no ulcers, spitting scars, and no calcinotic sites on the hands. And general physical exam, other part like trunk, back, and lower limb, there was generalized xerosis with scaling, but no obvious calcinotic oozing sites or ulcers seen anywhere else.
But now, what are those sorry to interrupt. What are those hypopigmented patches?
These ones, ma'am. These could be other Gautrans, which is present elsewhere also, ma'am. We can have Gautrans on the elbow, shoulder, medial malleoli, and other sides.
What is it called? So these are not palpable, right?
No, ma'am, these are not palpable.
So this is called Gautrans sign.
Gautrans sign, yeah.
Yeah, okay. Okay, go on.
Yes, ma'am. So coming to the central nervous system examination. Yeah. So the child was alert, well-oriented, sitting on the mother's lap at the time of examination. Cranial nerves, there was no obvious abnormality. And this is a short video of her gait where we can see that the gait is waddling. She can walk without the support of her mother also. Yeah, I think, yes. This will be a little more clear. Yeah, so this was the waddling gait she presented with. And bulk was equal in all the, there was no asymmetrical muscle loss in either of the limbs. And tone was decreased in all 4 limbs with power in the shoulder and hip showing maximum reduction with 3/5, and the rest of the distal groups for muscle were well preserved with 5/5. Now I tried to do MMT8 in her, ma'am, and it came to around 56. Now, CMAS alone, I could not complete the questionnaire because she was not willing to do other parts of the examination. So MMT8 was around 56, ma'am.
Okay.
And yeah.
And again, you mention it, right? So it was the right way of, like the way you mentioned, you always have to mention that you've also done a functional scoring. So yes. It was either CMAS or MMT8. And again, wonderfully explained that you couldn't perform CMAS properly because child was not compliant to a lot of instructions that you give in CMAS. Fine, next.
And next was this video I just put to show that she was unable to get up after sitting on the stool, and the squatting, she just refused to squat on the ground, but even while on this low height stool also, she was unable to get up from it. So, yeah. Reflexes, superficial plantars were flexor, and deep reflexes, most biceps, triceps, knee, and ankle all were absent, ma'am. And sensories and the rest of the CNS examination was essentially normal. And other system examination, again, cardiovascular, respiratory, parabdomen, they were not significant. Nothing was significant, ma'am. So coming to the final diagnosis of 4 years.
Sorry, Deepti, again, sorry, I'm disrupting you again. You did not mention calcinosis.
Ma'am, actually, currently, she doesn't have any active calcinotic sites or a calcinosis wound which is oozing. Only what was there 6 months prior when the mother gave me the history, but that has settled now, ma'am. There is no active site right now.
So nothing palpable?
No, ma'am, nothing palpable. No, neither on the chest or on the back or in the axilla. The previous one was there on the medial aspect of the axilla, which is not there now, ma'am. That was around 6 to 8 months back in October 23 when she had that.
Okay, fine. Go on.
So coming to the final diagnosis, a 4-year, 10-month-old girl child with bilateral upper and lower limb proximal muscle weakness with skin rash and history of calcinosis with no obvious respiratory compromise. I would like to consider a diagnosis of juvenile dermatomyositis.
So are you done with your
examination? I'm done. I have investigations and treatment next month.
Okay, so this is your only diagnosis, or would you like to consider something else also after examination?
Ma'am, if I had gotten any evidence of involvement of other CTD picture, like if I had some respiratory compromise, like chest showing some crepitations in the form of an ILD, or if there was some obvious digital ulcers, spitting, or a Raynaud's phenomena like picture, then maybe I could have thought of an overlap CTD myositis, ma'am. But since the disease was confined predominantly to the skin and muscle, and the rash was typical of a JDM rash, I would like to consider JDM only as my primary diagnosis, ma'am.
Wonderful.
Maybe I think for a postgraduate level, you can add whether how much is the disease activity, whether it is mild, moderate, or severe, or if there are evidence of damage, like Himanshi said, calcinosis.
Yes,
so
sir.
previously she had a cancerous, one or two sites were cancerous, now they are inactive. So
Now,
damage basically, and the activity of the disease, whether it's a moderate and other organ involvement, if
okay.
at all they are.
The
So
diagnosis itself.
complete the
Okay.
diagnosis of JDM and any specific clinical features which can point towards the prognostication of the disease, or like we have got an association with the myositis antibodies, where there are certain features which are characteristic of certain associated myositis antibodies. So if you have got, then you can add to that.
I
Suppose
think
if you,
we'll add after the investigation. So she'll tell us the investigations also.
okay, sir. So shall I go ahead, ma'am?
Yeah.
To the investigation. So the first time the child visited to us was in August and September 2022. So these were her investigations at presentation, ma'am. So she presented with the hemoglobin of 9.8 with the MCV of 75, counts of 9,700 with a platelet of 2,37,000, mild elevation inflammatory marker, ESR of 34, CRP of 2.1, liver enzyme showing 74 and 26 with CPK 388 and LDH of 732, ma'am. And after this, actually, I would we did a whole body stir. In this, we could see that there is diffuse edema, which is seen in, actually the neck muscles are not seen in this picture, but we can see that the muscles of the thigh, that is quadriceps, are having good uptake with hyperintensity on T2 stir imaging. So based on this, since we had a clinical suspicion of myositis, we sent the myositis panel, and myositis panel showed positivity for SAE1 antibody. And an NFC nail fold capillaroscopy was also done, in which we can see that there is disorganization, ramification with giant capillaries and dropouts which are present. So following this, she was started on, yeah, and this was one more X-ray which we had where we did when she presented with calcinosis, where we can see there are few sites of calcinotic patches in the upper part of the chest and on the neck, ma'am, and also here in the medial part of the axilla. So these were the investigations, ma'am. Should I tell the treatment and the further course?
No.
So now you can add on to the diagnosis.
Yes,
like
sir.
Activity, damage, vasculopathy, what additional things you got it?
So now, sir, yeah. So now in this diagnosis, now we can add a positivity for a myositis specific antibody like SAE1 positivity with a definitive evidence of calcinosis, which we got on X-ray. And there is activity going on because the muscle edema is present on the stir MRI. And damage-wise, it's only calcinosis which is there right now, sir.
Okay, so again, it's important to do some disease activity marking here so
Okay,
that you
ma'am.
do not miss out on anything that you just said. So there are
Okay.
disease activity index, which is very well, it's very well established in patients with myositis. So you can actually put that here because that includes a lot of things, including patient visual analog scale, physician in visual analog scale. It has muscle enzymes, which is a part of it. So that would be nicer so that you do not miss out on anything. And after that, you have to tell us that, how much is the disease activity and how much is the disease damage.
Okay, I missed out on that. I'll make a note of disease
So
activity index and damage index.
Yes. Also, you'll tell me about the enzymes, the muscle enzymes that were done in this patient, and you will tell me something about all those enzymes.
So the first enzyme which we did was creatine phosphokinase, ma'am, CPK.
Okay.
This was borderline elevated, was around 388. Our lab cutoff is around 270 to 280. Then CPK may not necessarily be elevated in all myositis patients. So we may get a normal CPK if the disease has progressed so much that all the muscles have gotten necrotic, then also we may not get. Or if all the muscles have gotten damaged, we may not get an elevated CPK. Or if it's an inclusion body myositis, sometimes CPK elevation may not be there. Or sometimes if it is early JDM also, we may not get that much of a CPK.
No, CPK is the earliest enzyme to get elevated. Okay, in myositis. So always remember, it's not a good test to do for follow-ups, but it is the earliest enzyme to be elevated in any patient with myositis. What about LDH?
LDH again is a marker for muscle damage, but not as specific as CPK because it can be other isotypes can be there because of, other sites can also cause elevation of LDH, ma'am. So LDH again cannot be used for, it can be used for prognostication, but not as an early marker for diagnosis.
No. So again, LDH is a very important marker. So it picks up relapses. So to pick up a relapse of a disease, CPK would not be a good test. You do an LDH then. What
So,
about liver enzymes?
again, liver enzymes, SGOT is more than SGPT in case of myositis, because AST can be released from the muscles also. Again, same thing, they can also show an early indication of a relapse in the disease if we see a persistent rise.
So there's a curve. So you just go and read that graph where they have shown how the muscle enzymes get elevated during acute flares and during the course of the disease, because they are actually important. See, every time you have to predict a flare, you cannot rely on inflammatory parameters, because sometimes inflammatory markers can just be normal in patients with dermatomyositis, especially. So so these enzymes are important, and just read about them in detail. Fine. Aldolase.
Aldolase in this particular case we have not done, ma'am, but that again can be done as a marker for a disease activity in the
Early disease market.
early disease.
Fine. Fine then. So would you like to tell us something about the MRI that is, so yeah, so now that we are discussing dermatomyositis, what is the criteria used for classification of patients?
Ma'am, the earliest criteria what was used was the Bohan and Preter's 1975 criteria, which contained the essential entry criteria was a classical heliotrope rash with goiter and
There
papule.
was no entry criteria. Entry
As a-
criteria is only for lupus.
Major criteria.
So there are just 5 criterias.
And the 4 other ones were EMG, muscle biopsy, proximal muscle weakness, and I told 3 of
Muscle
them.
enzymes. Muscle enzymes.
Yeah. So presence of the skin rash with 3 of them is definitive diagnosis, with 2 of them is probable diagnosis, ma'am.
Okay.
And,
And
the current.
Sorry. So what is the criticism of that criteria?
It did not involve MRI or myositis antibodies, ma'am, and we do not do muscle biopsy so frequently in children. So that's the reason maybe we cannot employ it all the time.
Okay, so no. So, I mean, yeah, that is one of the critique for that criteria. But the important thing was that it only gave 2 classifications. So they had just divided patients into either dermatomyositis or polymyositis. So
Yes,
there was, other myositis which were not getting classified based on the criteria. Then what were the modifications?
Then now currently what we follow is the ACR ULAR classification criteria, where we have scoring system with or without muscle biopsy. And based on that, we can say if the cutoff is more than a certain score, then we say it is definitive dermatomyositis. And if it is less than, then it can be possible. I think it is 9, more than 10 or something. I'm not able to recollect.
No need to learn it also, because it's a program generated thing. So it's fine. And also they have they've included the other myositis also.
And
So
also MRI was also a part of the criteria.
Yes,
MRI
yes.
antibodies are all part of the current criteria.
Okay. So then NFC, what about nail fold capillaroscopy? What is so unique about dermatomyositis?
Dermatomyositis, the typical finding what we see as bushy capillaries is what we see in JDM typically, but it also helps in predicting the prognosis of the disease, so that if we see in the active phase of the disease, we see more giant capillaries and bushy capillaries. And if we see these changes are not resolving or persistent, then maybe we can predict the clinical flare also of the disease, ma'am.
Okay, so so basically we can take an entire session on NFC. So but what are the others? So you said bushy capillaries, that is one.
Capillaries, giant capillaries, capillary dropouts, and
Yes.
microhemorrhages and ramifications, ma'am.
And how is it different from scleroderma?
In scleroderma, we don't get as many bushy or capillaries as we see in JDM. What we see there again is divided into early, active, and late phase. In the active phase of scleroderma versus JDM, which are most similar, the presence of these giant capillaries and bushy capillaries is more towards JDM, and hemorrhages will go more towards scleroderma, ma'am.
And dropouts will be much more in scleroderma as compared to, and you call it bushy arborization. So basically arborization is the word that I was looking for.
Ramifications, I told, arborization, I got it.
Yes. Fine, I think we can move on. MRI, so yeah, MRI. So what do you see in MRI, and what all MRI is useful in myositis?
Ma'am, MRI is basically done in scenarios whether we don't have a typical skin involvement and we want to see whether it is only clinically amyopathic or actually amyopathic disease if we don't get any involvement on the MRI. And next, it can help us to know the extent of involvement, like what all muscle groups are involved. Then if we are planning on a muscle biopsy, it will guide us in which is the correct site to biopsy the patient. And what we see on MRI is mainly the muscle edema, which is seen as hyperintensity on T2 and stir-weighted images.
T2 fat suppressed.
Fat suppressed, T2 fat suppressed and stir images, ma'am.
Yeah. So do you give contrast here? Do you use contrast here?
You don't need contrast in
You do
this.
not need contrast here. So these muscles, because of edema, they light up. So this is what you see on T2. What do you see on T1? Do
On
you use
T1,
T1 also?
if there is a long-standing disease, we can see atrophy of the muscles, ma'am, like a quadriceps atrophy or a sartorius atrophy if it is involving the thighs. So that can be seen on T1, and yeah, that's all, ma'am. But again, it will not help us to differentiate the etiology of the myositis as such. We can know that there is some inflammation going on in the muscle.
Okay.
So
Fine.
Deepti, as you said,
Also-
muscle biopsy is rarely required now. But then if you do a muscle biopsy, will it be telling you something additional information?
So, sir, one muscle biopsy will help us to phenotypically, characterize the disease, whether it is dermatomyositis or polymyositis, because the pattern of involvement is perifascicular in dermatomyositis and it is more endomysial in case of polymyositis. And next is we can look for the prognostication, like if we get more of infiltration and loss of nuclei than less basophilic infiltration, and that will be an indication for a chronic disease. And if we see that the patient has more inflammatory marker, more inflammation around the vessels and the muscle, that could probably indicate that he's more going towards an ulcerative or a protracted course of the disease.
Right. So prognostication also will be useful. Is there any conditions where you can get a necrotizing?
Yes, you can get immune-mediated necrotizing myopathy also, which is usually associated with anti-HMG co-reductase antibodies and anti-SRPs. What we
Right. Then
see.
can that guide you regarding the treatment also?
Yeah, the strength of immunosuppression can be decided after the muscle biopsy, like what immunosuppressive therapy we choose upfront. If it is necrotizing, maybe we will go for a higher immunosuppressive therapy than going ahead with the first line like methotrexate or glucocorticoids only in case of non-necrotizing
Right.
myositis.
One more question about MMT and CMAS, right? So in children it's difficult many times because they don't obey the commands, and then
Yes,
so how it is different, though MMT is not time consuming, you can do it quickly in the clinical settings. What it lacks?
We usually do a single-sided analysis in MMT8, sir, if we do, that is one thing. And next, we do not have the functional status because of the disease activity. Like, you're only testing the power in the clinic. We do not know what is the activity level of the child at the home, which is gotten affected because of the MMT.
So MMT usually will look at strength.
Yes.
And CMAS will look at strength plus endurance. Endurance means how many times you are able to lift the weight.
How much second you're able to keep the position and
MMT. So that's why possibly sometimes you may have to do CMAS also.
okay, sir.
Right. I think we can go ahead.
Okay.
So just to add on, there's another modification of MMT8 and CMAS that has come up, where they have combined 3 functional elements of CMAS and they've put it in MMT8. And MMT8 is not unilateral. So there are 2 different scorings for it. So one is one-sided and the other one is two-sided.
Yes, ma'am.
Yeah.
Usually what we do is one-sided with 80, what we score.
Yes.
Ma'am, but what was that modification you told, ma'am?
So
With
it's by the group in Italy by Dr. Ravelli. So you can just Google it. It does not have a name. It's just a modification of MMT8 that they call it.
components.
Yeah,
Just one
3
more thing I
functional
want-
components are there.
Okay,
Do you
ma'am.
do follow-up NFCs in JDM? Is it of any relevance?
Yes.
Yeah.
Yes, we can do the follow-up NMCs, though we don't have any guidelines as such to say that if you see these particular changes in NFC, this will predict a relapse. But we can do follow-up NFCs, and it's been seen that if new changes in a NFC, like fresh bushy capillaries or fresh dropouts or fresh hemorrhages, can indicate a clinical relapse also.
No, I meant response to treatment.
That also is seen, ma'am. Even a response to treatment is also seen in case of NFC in JDM, ma'am.
So if you have persistent NFC changes at the end of the 6 months of treatment, then there are chances that it may correlate with the longer disease course, and then there are chances they will take a longer time to go into remission. So that's why we do monitor them periodically at 3 months and 6 months.
Okay.
And Deepti, you'll also tell me something more about muscle biopsy. So how do you differentiate a polymyositis and dermatomyositis biopsy?
So, ma'am, dermatomyositis has a endomysial and a perivascular infiltrate, and we have CD8 T cells which are there, and the MHC which is deposited is perivascular. And in case of polymyositis, it is ubiquitous MHC, ma'am.
Yeah, tell me. Yeah. So MHC1 expression happens in cases of.
Ma'am, from what I remember, the MHC expression is the same, but the distribution differs. Like it is ubiquitous in polymyositis and it is perifascicular in case of dermatomyositis.
No. So dermatomyositis and polymyositis have very different histopathology. So
Yes,
you
ma'am.
read about it.
Okay, ma'am.
It's beautifully given in Cassidy. Especially the immunofluorescence. That is something that you should read up.
The MXA expression and IHC is more in case of dermatomyositis.
CD4 MHC1 expression, which is more in cases of dermatomyositis, and polymyositis is more of a CD8 disease. So, the destruction there happens because of perforin granzymes.
Yes.
There's much more destruction in polymyositis as compared to dermatomyositis. So you just read about it. Fine, we'll move on. We'll move on to treatment.
Okay.
Yeah, go ahead. Yeah.
Okay. Coming to the treatment, yes. So in August 2022, once the diagnosis was established, after 3 pulses of methylprednisolone at 30 milligram per kg per day, followed by 1 mg per kg, and then we started her on methotrexate injection at 50 mg per meter square, along with hydroxychloroquine and sunscreen. Then in August 22 to Feb 2023, she was doing well, and there was slow tapering of steroids up to 5 mg. She was continued on methotrexate and HCQ. September 2023, we tapered the steroid to 2 mg alternate day. But in October, once we made the steroids into alternate day, she started having fever, and this was the episode of calcinosis which was there. And laboratory also showed high flare with rise in ESR. So then again, the steroid dose was increased, and until March 24, she stabilized with a minimal increase in the glucocorticoid dose. Now, in again May 2024, she did not have an overt episode of calcinosis, but she presented with some pain. And since lab shouldn't increase DSR and CRP, we thought of going slow on the tapering of steroids. And then once the steroids, currently she's on 2 mg 2 mg prednisolone with methotrexate and HCQ, and she's doing well. And the pain has settled, and there is no new calcinosis or no new onset of muscle weakness, ma'am.
Steroid is increased to 2 mg or 2 mg per kg?
No, ma'am, 2 mg per day. That she's 13 kgs, ma'am. 13 kgs.
2 mg per day is a very low dose.
She
came in a flare, right?
That was May 24, ma'am. She had actually, that was not a exact flare. She had an acute gastroenteritis episode also that time, ma'am. So she complained of some minimal pain in the forearm, which was not even like a calcinosis. So we thought, since we had stopped the steroid in March 24, probably it was that she had some minimal flare. So we just put her back on the dose. She was doing well and continued it. Now she's again on tapering doses of it and is doing well, ma'am.
So you didn't do anything when the calcinosis developed?
That was in October 23, when there was a frank calcinosis. We gave her a symptomatic management with antibiotics, and we increased her glucocorticoid that time. But apart from that, we did not change her immunosuppressive therapy as such, because there was no other evidence of a disease worsening. That's the reason we stuck on to methotrexate and HCQ at that time, ma'am.
Chalo, theek hai, okay. That's all? I mean, that's all with your presentation?
Yes, ma'am. Right now, current status is she's doing fine on the medications like 2 mg of methylprednisolone, HCQ, and methotrexate, ma'am.
Methotrexate, how much?
15 mg per meter square she's getting, ma'am.
Absolute dose?
0.6 ml of the 25 mg, which comes to around, I'll have to just check, ma'am. 0.6 ml of the 15
mg. Okay, theek hai, fine. So you're done with the treatment?
Yes, ma'am. Right now,
we can ask you questions.
Yes, ma'am.
Okay, Deepti, wonderful presentation. So you have done a very good job, especially because it was a pediatric case, and it's a totally different ball game. I'm sure Suma ma'am and Oswal sir will agree that managing patients, pediatric patients, is much more different. You do not just manage the patient, you manage the entire family.
Yes.
So yeah, so a lot more challenging it is. Fine. So dermatomyositis, you have very well presented. Everything was in place. So I must congratulate you that you are very well prepared for your exams. So all the best for that. Fine. So you'll tell me about clinical trials that have happened in juvenile dermatomyositis.
So, ma'am, regarding the clinical trial, the last, we have different drugs which used in dermatomyositis include the conventional ones like methotrexate and mycophenolate.
No. I'm asking about clinical trials that have happened in patients with juvenile dermatomyositis. And juvenile dermatomyositis is the only juvenile rheumatological disease where we have proper clinical trial. So you'll tell me the name of the trial. You'll tell me everything about it.
One I'm aware is a RIM trial, ma'am, that is rituximab in myositis trial, where it was about randomized double-blind control trial for rituximab in refractory adult and pediatric dermatomyositis, which included around 83 children, I think, ma'am. And they gave rituximab at week 0 and 1, followed by week 8 and 9. And they saw that...
No, two arms were there. So,
RIM...
I think you just... Yeah. RIM trial basically was a trial to establish an early rituximab versus a late rituximab.
Yes.
You're confusing it.
Yes, ma'am. Okay.
So yeah, go on.
Remember that they found that either of early or late did not have much of a difference in the response to therapy. And but they did have, like, as compared to the ma'am, I'm not able to recollect the exact.
Go ahead and read it. It's fine. It's an important trial. Besides that, also, there is a very, very important trial on juvenile dermatomyositis.
Dermatomyositis you're talking about, ma'am? Or,
Juvenile dermatomyositis I'm talking about. Exclusively done in juvenile dermatomyositis. It was an open label, multicentric trial.
In rituximab only, ma'am, or something?
No, methotrexate. So it was a study where they had seen that only prednisolone or addition of methotrexate or cyclosporin made a difference to the disease course, disease outcome in patients with juvenile dermatomyositis. It's a very important trial because I said that is one of the only clinical trials in pediatric rheumatology. Go ahead and read it. It's very important. I think it was in 2015. Just go ahead and read it. Very important trial. Fine. So fine. So you know about steroids, you know about methotrexate, you know about... So tell me about IVIG, use of IVIG in dermatomyositis.
IVIG is used in cases of refractory or severe life-threatening conditions, ma'am. Like if the patient presents to us upfront with dysphagia or GI vasculopathy or a severe pharyngeal involvement and was refractory to first-line glucocorticoids, then we can try IVIG. And the advantage being you also have, it can be given in a setting where you also have a concurrent infection. So then again, IVIG takes a role. And we can give IVIG upfront and also as a maintenance doses every 1 month at 2 grams per kg.
No, maintenance is 1 gram per kg. And in severe disease, IVIG is not the only thing that is given. So say a patient of juvenile dermatomyositis comes to you with severe weakness, with a classical rash, also has some pharyngeal and respiratory weakness. What would you do? How would you approach treatment?
Yes, ma'am. So first followed by, I would give her pulse glucocorticoids, and followed by that, since the disease is severe, I would like to take a decision whether to give her upfront rituximab or cyclophosphamide. But since rituximab takes time to act, at least around 4 to 6 weeks, and cyclophosphamide acts in around 8 to 10 days, maybe we can give her a dose of cyclophosphamide, see how the disease activity improves, and maybe then switch over to rituximab if required.
How do you give cyclophosphamide then?
As in, ma'am, the dosage you're asking.
Yeah. So
I think the dosage in
not the dosage. So what is the schedule like? So how do you give you decide to give cyclophosphamide to a patient? So how do you go about it? How, like,
glucocorticoids, pulse doses, then we can give the first dose of cyclophosphamide then, ma'am.
Second dose, will you give second dose or you will directly switch over to rituximab?
Prefer switching over to rituximab, ma'am, rather than giving a second dose, and see for the response. If like at day 10 or day 15, the child doesn't show any improvement, then maybe we can directly switch over to rituximab, ma'am.
But rituximab will take almost 2 months for its action to come. It may even take longer. So would you give second dose of cyclophosphamide after a month or not? This is a practical question that I'm asking.
From few cases what we have handled, we have gone ahead and given rituximab and given 1 more pulse of steroids if required at that point of time, ma'am. That's the reason I was contemplating on giving 1 more dose of cyclophosphamide.
Okay. Along with that, you can also give IVIG. So what we do is, we do a very lupus-like protocol for these patients. So we give monthly cyclophosphamide.
Yeah, like
so sort of an induction. Yeah, very much like lupus. So for severe cases, only for severe cases. And, rituximab again is an option which can be offered to patients. Fine. Will you tell, sir, do you want to ask something? Sorry.
Yeah, severe cases like previous hour cases has received cyclophosphamide, and along with that, the patient you remember Mallar, NXP2 antibody positive. So that child received IVIG for first 3 months along with cyclophosphamide. So you have to choose between the depending upon the disease activity. Many children may require, those who come as a medical emergency may require IV cyclophosphamide along with IV IgG for first 3 months, and then or additional methylprednisolone also in between if required. And it's likely those children who have got a severe disease activity may have slightly longer duration of stay in the hospital. So you may not say it's a refractory, but then they may require for first 3 months definitely you can think of giving double immunosuppression there along with IVIG. So you already said about rituximab and children having severe disease using cyclophosphamide. So when you will call this as a child who is a refractory JDM?
Sir, I mean, after giving these immunosuppressive or like method said when we have started, sir, like
if you already given IVIG and cyclophosphamide, then definitely if they are not responding, then you will probably think of a refractory case, and then
maybe at least 4 to 6 weeks time for any drug, I mean, for the decision to be made whether it is refractory or no, sir. Then maybe we can call the disease refractory and switch over to next line of therapy then.
Right.
अच्छा, इसका भी एक criteria है. If you read about it, this also has a criteria, disease outcome करके. So when do you say a patient is in clinical remission? When has he completely off therapy? So there is a criteria for it which you can read. It's from IMAX. So you can actually read about that also. When do you say the treatment is not working? So that is also when the muscle enzymes have not dropped more than 30%, or when the clinical improvement is not more than 20%, that is when you say the patient has not responded to therapy, and that is when you sort of switch to another therapy. And as sir has mentioned, you give good amount of time, 2 to 3 months before switching off to another therapy. Meanwhile, you always give a little higher dose of steroids, or you can use IVIG to tide over that crisis.
There are also patients who develop dysphagia during this period, you know. When they come, they just have a limb weakness. And we've seen after 2-3 weeks, they start developing difficulty in swallowing and all. So I think these also will be considered refractory only, no?
Many times discordance also, because your other muscles may improve, muscle enzymes may improve, but your dysphagia is still persistent. So these children do require intensive therapy, as well as may require sometimes RT feeding or gastrostomy also for a few months till they recover. So there can be a discordance in improvement also as compared to what has been.
The antibodies which have more dysphagia, is there any differences?
Usually NXP2 is supposed to have more of dysphagia, ma'am. Even SRP can have more of dysphagia, ma'am. But apart from that, I think
these are the main two.
Yeah.
NXP2, I think, responds better. SRP is poorer prognosis. No?
NXP2 also is seen in more of a younger children, and they are more likely to have more of a prolonged course, and then associated the prognosis wise, they are not much better as compared to those children who have got a TIF1 antibodies.
Yeah, so we have about 7 to 8 minutes. So
yeah, so what are the other manifestation of damage you are supposed to see in child other than calcinosis?
One is lipodystrophy, sir, if it is present. Then next is ILD. Again, it may not be considered damage. It can be a part of activity only. Then next, therapy-related damage, if we have some steroid-induced osteoporosis or cataract, which is developing, that can be another marker of damage, sir. And
so
then
you differentiate between myositis relapse versus steroid-induced myopathy? Very favorite question of all examiners.
So ma'am, myositis, so clinically again, both can be involving predominantly the proximal muscles. So that will be difficult to differentiate. Next is the duration of steroid intake, which they have taken prior, though it can occur with minimal doses like 1 mg per kg also. Then laboratory wise, the enzymes may not be as elevated as we get in steroid myopathy, but in myositis flare per se, they can be elevated.
Yeah,
then
so it's the enzymes. enzymes are usually not elevated in steroid-induced myopathy, while other enzymes can be elevated. And the second important thing.
EMG, again, we can get some differentiation, ma'am. Probably in EMG, we may not get the fibrillary potentials and that insertional activity what we get in myositis and steroid myopathy. And if we do a biopsy, then it is usually type 2 fiber dominated in case of steroid as compared to myositis, which is type 1.
Right.
Well answered.
So,
Well answered.
the last two questions on prognosis.
Yes,
What
sir.
is the prognosis of these children who get a first episode of JDM? Do they go into complete remission lifetime, or they can have again and again JDM outflares?
It's known to be a chronic disease with acute exacerbations coming in between, but they can go into remission, but the remission takes time, at least 6 to 8 months to put them into complete remission. So remission is known with favorable antibodies, like if you have an MI2 or those kind of antibodies are more favorable to therapy and go into remission more frequently as compared to other antibody phenotypes. So going into remission probably depends on the clinical phenotype, what was the, how quickly they came into therapy and what was the associated underlying antibody which is there and how much damage was already there before we started the therapy.
So 1/3 of can have a monocyclic course, 50-60% can have a polycyclic course, and few children can have a active disease with going into remission and again coming back. The last question is, are there any long-term implications of the persistent disease activity in children? They get a malignancy, they are prone for malignancy if you have got a persistent disease going on.
Malignancy is not as common in children as compared to adults, sir. Adults are more prone, but we can still have like leukemias, lymphomas, and some CNS malignancies have been known to be associated with JDM, but definitely not as common as it is in children, sir. I mean, and adults.
And last comment on cutaneous disease activity. How to monitor cutaneous disease activity?
As in
Okay, so you can read about that. There is a CAT disease activity screening, disease activity scoring system is there.
There's a question in the chat box for the moderators. And what is the agent of choice for ILD in JDM?
So, should I answer, ma'am?
Yeah, just one. You can answer in short because Dr. Suma will also take the class of that. You can just
Yes.
answer in brief, yeah.
So ILD is a severe manifestation of JDM, and we tend to be very aggressive. So as previously mentioned, we tend to give cyclophosphamide for these patients. Rituximab also has been tried for some patients. So it's basically an aggressive therapy of multimodal aggressive therapy that we use in ILD. CNI usage in children, it has been, there have been some small studies where they've used tacrolimus, especially in a more aggressive disease. There have been some positive responses to its usage, but we do not use it as a mainstream therapy. We rather stick to methotrexate rather than cyclosporin or tacrolimus. So that is our usage.
Yeah. Okay, so I think we will just give a short feedback. I think we'll just conclude Dr. Oswal and Dr. Himanshi. Yeah.
Yeah. So in conclusion, juvenile dermatomyositis is a little different from the adult dermatomyositis that is traditionally seen, especially because children tend to do well with therapy. When we talk about dermatomyositis, it is associated with a bad prognosis. Most patients end up having a malignancy, but that is not the case with juvenile dermatomyositis. Kids tend to do well if treated early, and timely management and correct management is very important for future prognosis.
And a feedback on Dr. Deepti's presentation.
She was wonderful. She very well answered all the questions. She's very well prepared, I would say.
Thank you.
So, Oswal, you are in-house, so you can be more critical. Yeah.
I think the crux is basically how early these children are referred to either rheumatologists or now presently we both are there pediatric rheumatologists, because in our series of cases all these children has come to us almost at the end of 5 to 8 months. So if the disease is going on for 6 months, chances of chronicity is much more. So early detection and early referral is the key of success of treatment of children with juvenile dermatomyositis.
Okay.
So I will not comment on Deepti's thing because she's our own student. So day in, day out, she gets critiques from our side. So I think Himanshu has rightly said about her presentations. So Kavita.
Yeah, so thank you, Dr. Oswal. Thank you, Dr. Himanshi, for sparing your time on Sunday. It was an excellent session. I think all the students learned a lot of logins today. So thank you very much. Deepti, you can stop sharing your slides. Yeah. On behalf of the Maharashtra Rheumatology Association, I extend a very warm welcome to Dr. Suma Balan. Dr. Suma Balan is the professor and head consultant pediatric rheumatologist at Amrita Institute of Medical Sciences. She runs the Department of Clinical Immunology and Rheumatology and a DM program at that college. She's an alumni of JIPMER Pondicherry. She's MD Pediatrics from JIPMER Pondicherry and MRCP Pediatrics UK. And she's also been the ex-chairperson of Pediatric Rheumatology Society of India. Today, her talk is going to be an extension of the case presentation. So we thought we will sort of discuss juvenile dermatomyositis completely. And she will be talking today on JDM phenotypes and recent advances in management. I can already see 2-3 questions in the chat box. They will be answered by the experts after the talk. Over to you, Dr. Balan. A very warm welcome to you.
Thank you so much, Dr. Kavita. I'm wondering now, after that excellent presentation and the very lively discussion, whether my talk's going to be superfluous. But we'll touch on, points brought up in the talk or in the discussion already during my talk too. So the thing about juvenile idiopathic inflammatory myositis is that over time, we have seen significant changes in the classification, the investigation, the prognostication, and the treatment. What started off in 1975 with the Bohan and Peter description and the initial diagnostic criteria has been reformed over the past 2 decades. And we actually have, better criteria now. And we also have understanding that other organs are also involved, the gut, the lung, the heart, the CNS, etc. And over the past decade, the MSAs and the MAAs, the myositis-specific and the myositis-associated antibodies have become more available to us, and they have helped us define phenotypes even better. And increasingly, from the muscle biopsy studies over the last few decades, we have improved pathophysiological understanding, and that JDM is predominantly both a vasculopathy and endothelial dysfunction. That goes a long way into understanding the problems that these children face, which is actually quite unique. And of course, the role of type 1 interferon signatures and the downstream effects is another very fascinating part of the pathology that is actually going to be translated towards treatment changes in due course. So if you look at adult dermatomyositis and juvenile dermatomyositis and what are the similarities and differences, JDM is actually a rarer disease. Now, the rashes can be atypical in JDM, and you can get a much higher rate of ulceration than you see in adult patients. And about 80% of patients will present with high muscle enzymes, but about 20% can actually have normal muscle enzymes at presentation sometimes. And amyopathic dermatomyositis is more common in adults than we see in children. The risk of malignancy, which is a very, very big part of, the initial assessment of adult DM, is very low in pediatrics. So I would say almost negligible. We don't even think about the need to rule out malignancy when we are assessing these patients. Calcinosis, however, is a big demon in our practice compared to what you see in adult patients. And looking at the MSAs, there are certain MSAs which are strongly associated with malignancy, like the TIP1 gamma. And in about 80% of patients, MSAs have been isolated, whereas in children, it's about up to 60%. And again, the association with malignancy is, again, not typical, even if the same MSA is being found in these children too. Vasculopathy, as I said before, is a very predominant part of the pathology of these patients. So first, let's look at the clinical presentation and the various phenotypes. So when we look at juvenile idiopathic inflammatory myositis as a whole, In children, it is the dermatomyositis presentation that is the commonest presentation. 80% of the cases have dermatomyositis. So they have rash, they have the proximal and axial muscle involving myositis. They often have edema, which can sometimes throw off the diagnosis in some patients. Vasculopathy is a prominent part of this particular presentation, and calcinosis becomes therefore a significant sequel. Polymyositis is significantly rare in the pediatric presentation, about 4 to 8%, and usually in the higher age groups. In the adolescent age group, they do present with very high muscle enzymes, and they can have cardiac muscle involvement, Raynaud's phenomenon, weight loss. And this is a group of patients who usually require a muscle biopsy. Most patients with juvenile dermatomyositis, we do not need to do a muscle biopsy for diagnosis or practice these days. Overlap myositis actually is the next common variety we see after dermatomyositis. And that is about 6 to 11%. And it can be an overlap between myositis with scleroderma, lupus, or even localized scleroderma. And these patients also can have Raynaud's, ILD, dysphagia, and arthritis. Amyopathic dermatomyositis, which is defined as more than 6 months of cutaneous disease without clinical muscle involvement, even if you can have elevated muscle enzymes, is a very much rarer phenomenon. And unlike the adult patients, generally has a better prognosis if you have pure amyopathic JDM. So this is the clinical phenotype when you see your patient. Can we also look at clinical phenotypes with respect to the antibodies that we see in children? So in the white Caucasian population, the commonest antibody described in JDM patients is the TIF1 gamma or the anti-P155. And these patients are, you must remember that there are 2 age peaks for JDM. So one is actually below 5 years, and the other is actually older age group, like pre-adolescent to adolescent. And when I say below 5, I mean below 6 years, you can say as a younger onset. But of these, you must remember that about 18 to 20% of total JDM actually present in under 4 years of age. And this actually can be quite difficult because very often this, unless the rash is very, very clear, the diagnosis can be missed in these patients because many other things are looked at in the clinical evaluation of the patients. The patients with the TIF1 gamma, actually, they tend to have more severe cutaneous disease. They tend to have significant ulceration, photosensitivity, and very chronic polycyclic kind of a presentation. And these are the patients who tend to develop lipodystrophy in the long term with metabolic disease. The next common antibody that is seen in the Caucasian population, who have mostly described the long-term studies that we have in our literature, is the anti-MJ or the NXP2, which again are predominantly presenting with skin disease, but severe muscle weakness. And this is a group of patients who develop contractures and calcinosis, and they can also have chronic persistent disease. Then in the Japanese cohort, actually, one of the commoner antibodies is the anti-MDA5. It is sort of the third most common in the other cohorts, but it is pretty common in the Japanese cohort. And here again, you can have amyopathic presentations, but they tend to have ulceration. They tend to have arthritis. They could have Raynaud's phenomenon. But what is significant is that this group of patients who develop ILD, particularly rapidly progressive ILD, and are a group to watch out for in that sense. And then you have the very classic textbook JDM, which is actually the anti-MI2 disease, where they present with a classic rash, a severe muscle weakness, which can be pretty severe, that can be so severe that they can present as generalized anasarca, they can present with dysphagia and require ventilation. But the good thing about this anti-MI2 is that they are also the antibody component that predominates the monocyclic group of course of disease in these patients. So actually, it can be a very rewarding group to treat. Regarding the other MSAs, like the anti-synthetase, anti-SRP, anti-HMGCR, anti-SAE, these are all much rarer in the pediatric age group. You can see they are generally more common in the Black ethnicity groups. And the anti-HMGCR is very rare in the pediatric group and usually statin naive, unlike what you see in the adult patients. The other kind of disease phenotype is similar to what is seen in the adult patients, but these groups are really rare in pediatrics. Overlap myositis is not so uncommon, and the commonest is actually with Rho52. And these patients again have an increased risk of ILD and chronic disease. PMSCL is the other one, and anti-UNRNP. We must remember that anti-UNRNP is not usually part of the the MSA profile and may need to be checked for additionally based on the clinical phenotype that the patient exhibits when they come to you. So if they have an overlap of myositis with a scleroderma or MCTD kind of pattern, please check for your UNRNP as well in these patients. Now, this was something I did last year. I just, in our national group, I just put out a small questionnaire, and about 10 centers replied to me to see what MSAs we see. Interestingly, most of the centers reported anti-MDA5 as being the commonest MSA that we see in India. The second commonest was anti-NXP2, and the third was anti-TIF1 gamma. So it is quite possible that genetically, different populations will have different kinds of disease phenotypes. And we do have to be aware of that. We are trying to set up a multi-center registry now towards collating these facts and reporting them so that we can learn better from our patients how to treat them. And I'll just show you some the real life patients with the autoantibodies. So this is a boy who presented a little late to us with the anti-TIF1 gamma antibody phenotype of JDM. And what is most prominent, yes, he has rash, he has ulceration, he had some muscle weakness, but you can see the lipodystrophy features on his body. You can see the thinning out of the fat areas, the specific features. And this is worrying because these patients develop early metabolic disease. And that is one of the sequelae of this phenotype. And this is anti-NXP2 JDM. And it's important, this is a group that actually, the MI2 and NXP2 are the ones who tend to present in below 4 years of age. And the younger the child, the more severe the disease can be. They can present with anasarca, actually, and with ulcerative skin disease. They can also have, the younger the child, the higher risk of calcinosis too. And apart from this picture, these are all pictures of the same child. You can see the extent of calcinosis that these children develop. And all these patients are presented pretty late, which is why they come with the body studded with with calcinosis far more than the emeralds that Nita Ambani exhibited in the Ambani wedding. Now, when we look at why did I put this picture? This little boy was only 2 weeks into his JDM presentation, and we started treating him, but we realized that he has already developed tendo-Achilles contractures, and that is how early contractures can develop in NXP2 related disease. And we have to watch out for this. And it's very important that we involve physical medicine early in these patients. And this is a girl about 6 years old when she came to us. She had been going around to different centers without a diagnosis. She was having fatigue, aches and pains, irritability, failure to thrive, chronic cough. And when we saw her, we actually spotted the various skin features of JDM, alopecia, the shawl sign, and clubbing. And this girl had ILD with anti-MDA5 JDM, and she responded extremely well with steroids and cyclophosphamide. And she is now in remission on maintenance mycophenolate. And this is the classic anti-MI2 JDM. This is a 2-year-old child who presented to us with all the classic rash features. And as I said, this is a fantastic disease to treat because this child who was in so much distress and so weak when she came to us is now running around the OPD, climbing over everything in my room when she comes for a follow-up. And she looks like she's going to go into the monocyclic group of patients, which is great for her long-term prognosis. And this was another young girl, about 8 years old, referred to a pediatric cardiologist with severe pulmonary hypertension. And when he assessed the child, they already started treatments, but the child wasn't responding well. So he asked me to have a look. When we examined her, she had absolutely no history or no signs of muscle weakness, but we could see a few Gottron papules on her, old and fading. And this prompted us to work up for muscle autoantibodies, and we got a very strong Rho positivity, Rho 52 positivity, and she had actually overlap of myositis with CTD, and she has responded extremely well after we started immunosuppression along with a pulmonary hypertension therapy. Her pulmonary hypertension has actually reversed and it is normalized, and she's off those medications just on maintenance immunosuppression alone. So that brings us to, while I said that we don't do muscle biopsies for the diagnosis to treat a patient with JDM anymore, we really have to thank all the researchers who have been doing muscle biopsies across the decades, which have helped us to learn the pathophysiology of this condition. And what we are increasingly beginning to understand is that we have a genetic interplay with environment. The environmental components could be UV rays, pollution, various infections, and there can be specific HLA types. And it's interesting that the HLA types described in TIF1 gamma phenotype of JDM and the TIF1 gamma phenotypes of adults are different, which shows why the diseases can look quite different in both age groups. And what has the biopsy studies shown us is that there is increasing type 1 interferon activity, which skews the T lymphocytes towards Th17 or a pro-inflammatory phenotype, and that causes a very autoreactive B cell compartment, which goes into autoantibody production and triggers off the disease. And the features of the disease, whether you're looking at the blood, the skin, or the muscle, is a combination of vasculopathy and endothelial dysfunction. And that is the hallmark of disease in these patients. Very excitingly, an engineered myobundle model was created using AI and other features in the last decade. This was done around 10 years ago, and they looked at type 1 stimulating this myobundle model with type 1 interferon signaling, and they found changes very similar to JDM in these patients, which they could then reverse with JAK inhibition. So these are all studies that have contributed significantly to our understanding of the disease and how we take these patients forward. And this, even in 2005, type 1 interferon signatures have been found to be significantly elevated in the peripheral blood, muscle, and skin of these patients. And it's also been seen that these signatures can be increased with different levels of the scores, dosage of the scores in different parts of the body. So, in different autoantibody phenotypes. For instance, the MDA5 phenotype can actually have higher type 1 interferon signaling compared to some of the other phenotypes. And all this brings us to how are we looking at the treatment aspects so far? I think the discussion that we just had was excellent in bringing out the clinical features, in bringing out how you assess these patients when you see them and how you investigate them. Now, the other important part is when a new patient presents to you with JDM, you have to look at the severity of disease. We'll come to that in a minute. we have to look at what is a systemic or organ involvement in the disease and try to elucidate what phenotype we're dealing with, the clinical as well as the autoantibody phenotype. And to reiterate what Dr. Jitendra already said about treatment decisions being made in a specialist pediatric center with a multidisciplinary team, this cannot be understated. It is a rare disease. To get the best outcomes, they need to be treated in centers where there is experience with treating these patients and also the available infrastructure to support all the complications that they can potentially develop. To guide our treatment protocols, we have consensus guidelines from the CARA, that's the Children's Arthritis and Rheumatology Research Alliance from North America, and we have the British Society of Rheumatology guidelines from 2022. So how do you look at what is severe disease involvement? You look at the various, organs. You look at, is there lung disease? How severe is it? You look, how do you rate severe skin disease? The presence of ulceration, edema, and anasarca are features of severe skin disease. How do you rate the muscle disease? You look at the severity of weakness, your MMT or the CMA score, the presence of bulbar weakness, and the presence of GI vasculopathy. All these are very, very significant because GI vasculopathy, Dr. Himanshi was talking to us about the nail fold capillaroscopy in these patients. So there has been an excellent correlation of nail fold capillaroscopy with GI vasculopathy in patients with JDM. And one of the ways to interpret the presence of GI vasculopathy is that giving oral drugs is not going to work at this point. You have to give parenteral drugs to get better action in the early stage of disease for these patients. Then the presence of CNS involvement is really rare, but it is obviously an evidence of severe disease. And if there is presence of cardiac involvement, it's a sign of severe disease. And as we mentioned before, severe muscle weakness, CMAS less than 15 or MMT below 30, the presence of muscle cell necrosis or severe inflammation on the muscle biopsy. There are actually specific muscle biopsy scores. And in the West, all pathologists rate JDM biopsies based on muscle scores, which help to prognosticate the disease and also plan treatment for these patients. At present, if we look at the basic consensus guidelines that we have, we look at, there are three aspects when you're going to manage JDM. So one is obviously the major part, the medications. The second is exercise therapy, which needs to be considered right early on in the disease, because even when the patient is very weak, you need your PMR involved to prevent contractures. And then you need a programmed, exercise therapy to get them back to fitness as they start healing from the disease. Then adjunctive therapies like use of sunblock, use of topical therapies, sometimes, especially if there is a refractory skin disease, one of the ways to handle it, and using vitamin D and calcium supplements, management of bone health is very important. Now, regarding medications, again, you have to see, are you dealing with like moderate disease or are you dealing with severe disease? You would treat them, you would approach them differently. If you're dealing with severe disease, like severe skin disease, severe muscle disease, severe organ involvement, then these are patients for whom you might want to give intravenous pulsed methylprednisolone along with cyclophosphamide with possibly additional intravenous immunoglobulin. Generally, when we see a patient who is extremely weak, who has bulbar muscle involvement, dysphagia, dysphonia, we would give IVIG upfront along with the initial induction therapy for this patient. And if you're seeing moderate disease, then you start with steroids. And we would still recommend giving a pulse first and then oral steroids, along with methotrexate is the first-line drug and preferably subcutaneous. Please remember that the actual incidence of GI vasculitis is fairly high. Endothelial dysfunction and vasculopathy is a very big part of the pathophysiology of JDM. And giving subcutaneous methotrexate makes a significant qualitative difference with improvement. for these patients, and using proper doses upfront is also very, very important. You can use IVIG if you think there is an indication for it at that point. The other important thing is also when we start treatment, I wouldn't be bothered by high ALT, AST in trying to keep off methotrexate, because most of the time these are actually reflecting the muscle disease and it's not actually a reflection of liver disease in these patients. Second line therapy is a wide range. You can add an IVIG, you can consider mycophenolate mofetil, you can consider calcineurin inhibitors, change to cyclophosphamide. I know azathioprine is in the list, but azathioprine is a drug that pediatric rheumatologists very, very, very rarely use in juvenile dermatomyositis, especially now. It was used initially, and the amount of evidence for it is really, really low, that it is very rarely preferred as a DMARD in these patients. If you have refractory systemic or skin disease, you consider rituximab, anti-TNFs. Now, this actually consensus is this article came out earlier, came out last year actually, and at this point, I have a feeling that in the years to come, JAK inhibitors are going to occupy a place quite high up in the list rather than as low down as here. And over time, as your patient improves, the aim is to wean off and completely stop corticosteroids, but maintain them on the disease-modifying drug. You try and evaluate whether you're dealing with a monocyclic or a chronic disease. If you're dealing with a chronic disease, don't stop the DMARDs for a long time. Keep them on the maintenance DMARDs. If you're dealing with a monocyclic disease, you can actually try and get them off treatment in about 2 years from onset. Now, what is the evidence? I think Himanshi has already touched on this. RCTs are being quite difficult to perform because given the rarity of the disease. However, we do have RCTs. The top RCT is a Printo one, which looked at subcutaneous methotrexate versus cyclosporin in JDM. And they actually found that both of them were effective, though looking at the pathophysiology and looking at the side effect profile, we would prefer to go with subcutaneous methotrexate upfront in most patients. Rituximab in JDM, like again, Himanshi told us it had 2 arms. And what was found was in this trial, it did not meet the endpoint. But however, about 83% of the patients actually improved. And what was found was that it takes time to improve on rituximab and JDM, but a good number of them do actually improve. I think this trial needs to be redone in a reconstructed fashion, and we may see better efficacy from this. Exercise in JDM, again, is an excellent RCT that has come out. That's worth reading. The rest of the evidence is all based on case and cohort studies, case series and cohort studies, and case reports too. Calcinosis is a major problem. We still do not have unified protocol for how you manage calcinosis. In interstitial lung disease, especially RPILD, can be very frustrating to manage with a very high mortality. And that is again an area where only case reports are guiding us at present. What would be the protocol for refractory disease? We actually need head-to-head studies in patients. And to reiterate once more, azathioprine is largely out of favor. Now, with all the recent understanding in the last decade, obviously, these drugs are a very promising force in JDM. And a review of the literature, again, case series and case reports only at present. They've been shown to benefit resistant or recurrent skin involvement, resistant or recurrent muscle involvement. Pulmonary involvement is a promising area. And this is one of the areas for use in where would its position come in rapidly progressive interstitial lung disease is actually watch the space area for JAK inhibitors in JDM. Calcinosis is another promising area. And as you can see, there is a side effect profile, but it's not There are a few worrying side effects like the increased BK viremia or viruria and the risk of infections that we are concerned about, potential of metabolic long-term side effects too that we need to watch out for. But however, as of now, with the limited evidence we have, there is promise. The maximum promise has been coming from tofacitinib, next baricitinib, and then ruxolitinib with the data that we have. Calcinosis is a real tough area in JDM. And we know that basically it's a reactive oxygen species, which is produced secondary to inflammation and within the muscle that's leading to mitochondrial calcification. And this is what is actually leaking out and causing the kind of calcification that we see in these patients. It can be very, very disturbing. It can be very painful. It can be a really, really difficult problem that these patients face. It usually starts a little later very rarely do patients present with calcinosis at the onset of disease. This is almost a sequelae of the disease rather than primary pathology itself. And that is possibly the most important aspect that we need to internalize. And the risk factors for calcinosis have been shown to be prolonged duration of disease prior to treatment. If you have nail fold abnormalities at baseline, again, showing the vasculopathy, reflecting the vasculopathy in these patients. If you have a chronic disease course, if you have lipodystrophy and calcinosis often go hand in hand, the patients with contractures. So anti-NXP2 is the autoantibody phenotype that is associated the most with calcinosis and also associated the most with contractures. And patients who have taken longer time to regain full muscle strength, higher muscle biopsy scores, and younger onset of disease, younger age at onset of disease. If there is one take home about calcinosis is that it is better prevented than treated. Aggressive initial management of disease can really reduce the incidences of calcinosis in the future. Whether we can completely prevent it, I don't know, but it can significantly decrease the risk of calcinosis. And once you have calcinosis, really, people have thrown everything but the kitchen sink at them. All sorts of drugs from bisphosphonates to uricosuric drugs to various biologics to intravenous immunoglobulins, even intralesional treatments have been tried. You can look at this thing. Most of it again comes from case series and cohort studies, and anything really has some pluses. So there are patients that have benefited, some patients have benefited from some have not benefited from the same. Slowly, what is coming of some, this thing is some kind of promise is the JAK inhibition for these patients. And our own, we presented this in both in the NCPR as well as in APLAR last year. Our own experience with using tofacitinib for patients with calcinosis. So we had patients, see, all this is in the last 3 years after tofacitinib became easily available for our patients. It is easier now to dose because we also have the liquid tofacitinib. And the thing about, again, is that we are actually using the polyarticular JIA dosing of tofacitinib in JDM patients. I'm not really sure it is appropriate. There has been some case reports that suggest that we have to use type 1 interferon signaling as a target to decide the dose that we need that will work in JDM. I think more work needs to come out before we embrace that concept, but it seems intuitively to be the right way to use the drug. What we have found is that in 8 out of our 9 patients, we had a reasonable recovery, a reasonable improvement with tofacitinib. At least 50 to 60% reduction in the calcinosis, and in one patient it was completely unchanged. I'll just show you one example. So this was a boy who presented, he had JDM. He came to me 4 years into onset of disease. He had been treated very underwhelmingly until then with just mostly spurts of steroids and nothing else. And then after we got his muscle disease beautifully under control, he came with this huge lesion in the pectoral area. And we tried various drugs, pamidronate, nothing really helped. So I sent him to the surgeon thinking it's just one large lesion, let's excise it. We don't like excising calcinosis because trauma can actually cause it to reform. But in this case, I thought we can try. He managed to excise the whole lesion. You can see that it is a little lesser in this picture, but it came back. He was very frustrated. The family were very depressed, very frustrated. It came back. At this point, I had actually tried tofacitinib sometime prior to surgery, but it didn't seem to make much difference. So we sent him for surgery. We stopped the tofacitinib because I was worried about postoperative infection. We just continued the methotrexate that he was on. And when it came back, we restarted him on tofacitinib again. And this time, it's gone. And the satisfaction is immense. It takes time. The one thing I learned with tofacitinib in calcinosis in JDM is that it does not go like that. I'll finish very soon. It takes time for...
Please mute Mr. Prasad. There's some background noise. Sorry.
Yes, ma'am.
Just mute. Yeah. Sorry, Dr. Sima. Continue. Yeah.
The other very, very difficult situation is the patients who present with rapidly progressive ILD. And there are actually case reports only. And currently we have expert opinion that if you have a patient with JDM, rapidly progressive ILD, especially anti-MDM5, you should treat them with combination immunosuppression upfront, not add sequentially one after the other. And when they say combination, they're suggesting steroids with calcineurin inhibitors along with cyclophosphamide or mycophenolate, and possibly add in JAK inhibition immediately or soon after. And this, however, is a case report where they added in rituximab after the patient was initially on high flow nasal cannula, got ventilated and went on to ECMO, after which, after rituximab, 2 weeks later, the patient has actually improved significantly. They could take off ECMO, decannulate, and now the patient is doing very, very well. Ferritin becomes an important biomarker since we don't have access to KL6, etc. in these patients. So the important thing is this is a small but a very, very highly important group because mortality is very high. And these are patients with whom we have to consider very aggressive treatment upfront. We probably need to discuss with experts before we treat them. So I'll end here. Prior to starting treatment, any treatment for JDM, the mortality was 30%. Now in developed nations, the mortality is less than 4%. I think our nation, we might have a higher mortality rate. I think in our series, we definitely do have a higher mortality rate. Infections are one of the reasons, and also complications of the disease, because unfortunately, we tend to get patients come to us much later after the diagnosis has been made and after treatments have been started in a very inadequate fashion. We need to, the pathophysiology and learning about the disease helps us to have better ways to limit the damage and complications. But we need to realize that damage increases linearly for each year of active disease. So treating them aggressively upfront really is the key. Damage domains can be cutaneous, it can be skeletal, it can be muscular, it can be endocrine. And all these should be factored in when we are treating these patients. And of course, it can also be ILD and cardiac related in the relevant patients. So the determinants of mortality or high morbidity in patients is actually high disease activity or severity of disease at onset, the duration of active disease, the presence of early organ damage, and functional disability in these patients. I think we need a lot more, multi-centers, RCTs and multi-center registries and also improving awareness of this disease so that they are actually diagnosed, referred early, and treated appropriately to get the best results from these patients. I'll stop here and we can all take questions. Thank you.
Thank you so much, Dr. Suma. It was a very comprehensive talk, covering all aspects of the phenotypes and good clinical pictures also, which will, help the students to learn, and extensive review and discussion about the management. So how do you manage the immunization schedule, with so many immunosuppressants? Do you have to modify that? And what does rituximab do? I mean, that is one place where do you need to?
So, one good thing is that these patients are all, generally most of our patients tend to be over 1.5, 2 years of age, and most of their primary immunization will already be in place most of the time. Even on stable immunosuppression, you can still give killed vaccines. It's the live vaccines that are a problem. So we try to get pediatricians to give them the injectable polio rather than the oral polio. We do have to be careful with things like chickenpox, which is a live vaccine and which these patients can be susceptible to. Most of the time, we don't have the time to give them the vaccine, to wait to start treatment. So these are certain things that we need to keep in mind. But for majority of the vaccines in this population, what we encounter are killed vaccines, most of which we are able to give for them.
So the ones you give rituximab, you don't need to give any boosters later. The B cell population recovers, no?
Yes, rituximab is a different ball game because some patients, though most patients don't lose their memory B cells, they can actually completely lose whatever vaccine memory they've got before, and you may need to actually think about revaccinations sometime after rituximab. Now we do have some guidelines from the EULAR pediatric the press group regarding vaccinations, and that can be referred to in these patients. We tend to see, generally, I don't think we've had many problems. We tend to give, I've used rituximab quite widely in these patients, and we've just followed them up and continued their vaccination schedule once they have, once they've passed that time period of CD20 suppression, B cell suppression.
We don't test anything before deciding to revaccinate.
Ideally, you should be checking functional antibodies, but I don't think we do that in all patients. What do you say, Himanshi?
Yeah. Himanshi, you're mute, yeah.
Yeah, so I agree with ma'am. So there are very fine guidelines that have recently been published by the press group on vaccination. So as ma'am has said, that most of the kids, when they come to us, they are older than 18 months or so when we kind of finish our primary immunization. So most of the kids have had their own share of vaccines when they were kids. Once they are on higher immunosuppression, we wait when they are in sort of a remission for some time, at least 6 months. And that is when we consider giving them live vaccines. But otherwise, if the disease has been stable on immunosuppression for quite some time, killed vaccines are something that we can give those patients. It's only about the live vaccines, which are given once they are off major immunosuppression for quite some time.
I think some questions Himanshi has answered in the chat box, but I think Dr. Suma, you can also give your experience and opinion. CNI use in children, because
yes, I think there is definitely, if you look at the consensus guidelines, they do say that your first choice can be between CNI or methotrexate when you start treatment for patients. But the thing is, be it cyclosporin or tacrolimus, they do have more unacceptable side effects compared to methotrexate. I would try to reserve CNI for the patient who has secondary macrophage activation at onset. I've had a couple of patients like that. And also probably for the patients with the anti-MDA5 and the lung disease, which can be probably a good choice there. For most other patients, I think subcutaneous methotrexate really is the best drug to go up front for patients with. The severe disease, it has to be a combination of cyclophosphamide and
What
IVI.
about tacrolimus you don't use in children?
Yeah, we do use tacrolimus. You can choose between cyclosporin and tacrolimus. Other than the fact that the cosmetic, the side effects can be lower with tacrolimus compared to cyclosporin, the systemic side effects are no different. So
Is PCP prophylaxis given in children?
yes, I think I wouldn't use PCP prophylaxis if they're just on steroids and methotrexate. But once cyclophosphamide or combination immunosuppressions enter the scene, it is definitely a good idea to use PCP prophylaxis. And also to be aware, especially the ILD patients, to be aware that when you're treating them, disease exacerbation can also be due to secondary infection. We've had patients with MDA5 ILD who've also needed BAL interim, and they've had aspergillus and PCP positivity that needed to be treated alongside their treatment of the disease. So we have to be, supportive care involves all these things for these patients.
Role of local or systemic infliximab in JDM or for calcinosis?
It's as I showed you, there are only case series. I mean, basically with calcinosis, people have been desperate. They've been trying to try different modalities. There are patients for whom infliximab seems to have helped. There are patients for whom, but it does not help everybody. So there is a buffet out there. We don't know what will help the patient. It's really trying to prevent it from happening that is more important, I think.
Anifrolumab, does it work?
No idea. Himanshi?
So I don't think it has been used in JDM. Of course, lupus, it is coming in a big way, but I don't think anyone has used it in JDM, even internationally. I might be wrong.
Intuitively, yes, but I don't think there's any report so far.
And what about bisphosphonates? How long do you give? Like, how long do you try?
6 to 12 months.
6 to 12. You
And
prefer
favipiravir is the recommended bisphosphonate for young children. Most of the zoledronic acid, etc., cannot be used until you reach a certain age. And so it means a monthly infusion. It has many other things going with it. It has helped a few patients, but not impressively enough to write it off as a definite call for these patients.
Any more questions? Anybody can unmute and ask. Yeah. So in ILD with JDM, which is your drugs of choice?
Himanshi, you want to go first?
Yeah. So ILD will mean a very severe disease. And of course, if it is associated with MDA5 positivity, so as ma'am said, so it has to be a multi-modality treatment. So cyclophosphamide is something that we give along with CNIs and JAK inhibitors. So it is a combination of all those medications. And even IVIG is added on. So we have to really pump in immunosuppression at that point of time.
So when do you put in
be very wary for infections also which crop up alongside in these patients. CMV, PCP, they are all uninvited guests in the party.
So you prefer CNI to rituximab here? I mean, IVIG cyclo, yes, to start with, but
see the consensus, expert opinion, all we have is expert opinion. And the recommendation from the expert opinion upfront is this. Having said that, the non-RP-ILD patients, the patients who have MDA5 ILD, all my patients so far who have done well, I've rescued on a combination of cyclophosphamide and rituximab. It is for the rapidly progressive ILD that this multimodality treatment has been advised. And I guess you could add rituximab also into the fray. I mean, because you're trying to actually address the pathophysiology from trying to close all the possible holes. That is the idea of this, because the mortality is more than 40 to 50% in these patients. So that is why it is so aggressive.
Okay, any more questions from anybody? Renu ma'am is here, Renu Sehgal ma'am.
Good afternoon, ma'am. This is Dr. Sri Lakshmi from Bharati Hospital.
Yes.
So any experience of overlap between systemic onset GIA with polymyositis in children, ma'am? because we had a patient who had systemic onset JIA in his childhood and later developed polymyositis at his 19 years of age, along with high ferritin, something like overlap of stills with polymyositis. In that case, how we go about with treatment now?
What was his autoantibody?
Yes.
Actually, due to constraints, we had done MRI and muscle biopsy. And MRI was suggestive of myositis, and muscle biopsy was suggestive of polymyositis, ma'am.
But did you
And
know
it's the
antibody levels, autoantibodies, myositis specific?
myositis specific antibodies we had not done, ma'am, because of cost constraints. And also his ferritin levels were high, CPK levels were high, and he also had continuous fever spikes. And he had a history of systemic onset GIA when he was around 10 years, around 5 to 6 years, and he was treated with Folitrax and he went into remission for 5 to 6 years. And later at 19 years of age, he started developing severe myositis along with high ferritin levels and fever. So
I get the feeling I'm listening to the story of a relatively amyopathic anti-MDA5 GDM here, actually.
Yes.
Because these patients can have high ferritins, they can present with fever at onset, they can be relatively amyopathic, and they can have fever. I mean, fever with secondary MAS as well. So that's the feeling I'm getting here, actually. Though you said your muscle biopsy was polymyositis, that is interesting. It will be good to look at this patient. But I've not heard of SJIA, and see, anything can happen in this world. I've not heard of this particular combination before. That's all.
actually, we had put him on tacrolimus, thinking he had overlap features, and he had completely gone into remission after like 3 to 4 months. So he's doing absolutely well now.
I think again you're proving our Himanshi's and my hypothesis about this probably being an anti-MDA5 JDM.
Yes.
Yes.
Maybe antibodies we can try again.
They may be negative if he's gone into remission, though.
Remission.
That's the only thing.
Okay, I think we'll conclude now. Thank you so much, Dr. Suma, Dr. Himanshi, for being here today. The students have really enjoyed. I've got separate messages, very, very informative. They've learned a lot. Thank you so much for sparing your time on a Sunday. Hope to see you soon at Aerocon or elsewhere. Yeah. Thank you. Bye-bye. Yeah.
Thank you, ma'am, for having us. Bye.
Good day to you. Happy Sunday.
A pleasure. Thank you.
Bye.